So, nasal high flow. How many of you feel confident in the mechanisms in nasal high flow? Show of hands. Good. Awesome. So we're going to really dive in mainly into the mechanisms because I feel that it's empowering to know how nasal high flow works, and the research that's coming out, it's still coming out, it's wonderful, and it's really changing the trajectory of how respiratory therapists take care of their patients. Let's see. All right, so high flow fundamentals. Well, we have a way of making this very confusing. We have numerous names for not only the interfaces, but also the therapies. High flow nasal cannula, high flow prongs, humidified high flow nasal cannula. As a therapy, we have high flow therapy or high flow oxygen therapy. We have various acronyms, and to make things even more interesting, we have brand names such as OptiFlow, Airvo, nasal, Comfort Flow, and high velocity nasal insufflation. But for the purpose of this talk, I'm going to try and keep it concise and just call it nasal high flow. So walking through the agenda, we're going to talk about a little bit about the origins, mainly the mechanisms of action. We're going to go over some of the evidence and then have time for Q&A and hopefully a round of high fives. So that's scary to me. So I feel that in the history of nasal high flow, we often talk about how comfortable things are, and I don't see how anything out of that apparatus would be comfortable. Oops. Okay, so here's an article in 1968 that an anesthesiologist that was in the lab playing with high flows found out that you can actually administer high flows up to 20 to 30 liters in an air while it being comfortable to the patient. And of course that had to be body temperature 100% saturated. Now I know you guys have heard 3744, we're probably going to talk about it a little bit, but it's really interesting. The reason why I wanted to bring this up is that nasal high flow has been around for quite some time, and it's just recent that we're really starting to see how we can implement it more as our first line of defense for our patients that come in. So just for semantics, I feel like we should talk about what respiratory support refers to as the application of ventilatory support through either a mask or a simple apparatus. This differs from your tracheal tube, Larry mask, or a tracheostomy, as those will be invasive. So in 1984 is when you see continuous positive airway pressure emerge, known as CPAP or PAP therapy. In 1992, you see non-invasive ventilation, BiPAP for Respironics, BPAP, and in 2000s, nasal high flow emerged. Now, I would be remiss if I didn't speak about the difficult times during COVID and how it really changed the trajectory of nasal high flow. As you can see here, the initiation of nasal high flow was really predominantly in the critical care units. However, during COVID-19, really highlighted the critical importance of nasal high flow therapy and really making it a vital option for those patients that were hypoxic. So you can see here that during COVID, you see a transition to 60% in the emergency department. And we're going to go into that, why that's important further. So as we consider the escalation of a patient's condition from very mild to severe, we have numerous therapies that we can utilize. So for those patients that walk in with oxygen depletion or are hypoxic, we can start with low flow oxygen and then gradually increase into nasal high flow. Conversely, those patients that come in with oxygen and ventilatory issues, we start with usually a bilevel device and then move to invasive ventilation. So during COVID, we observed that non-invasive support could effectively address these hypoxic respiratory failure through the use of nasal high flow. So we really should consider nasal high flow as a part of that non-invasive respiratory support option. And increasingly, the literature really does recognize high flow as a form of non-invasive support. I'm not saying non-invasive ventilation, but non-invasive support. And I really feel understanding the mechanisms behind nasal high flow it's really going to help you understand why researchers are starting to adopt this thought process. So mechanisms of action. I can't tell, I get really excited about this part. So what is nasal high flow? So nasal high flow is the delivery of heated humidified air up to 70 liters to a patient using a nasal high flow cannula. Now I'd like to add the caveat that meets or exceeds the inspiratory demand, because if we're not meeting or exceeding that inspiratory demand, we are not providing nasal high flow. So let's go into the mechanisms. So the first mechanism is respiratory support. So we have dead space washout, dynamic positive airway pressure, then of course we have oxygen if needed, and then my fave, optimal humidity. So let's begin and talk about the reduction of dead space. So this is the flushing out of the upper airway, and this is a great study by Moeller, who points out in the video that we're going to watch here in just a second, that as we enhance the pressure from 15, 30, and to 45, we're enhancing the time not only it takes to wash out, but it wash out altogether. So let's see if we can take a gander. So you can see the control on the left, all the way to 45 liters to the right. And so those are isometric tracers that were in a patient's upper airway. So you can see, or you can surmise, as you increase the flow to 50, 60, you're going to actually wash out that dead space even faster. So Mori work compares a simple mask to that of nasal high flow therapy. And this kind of brings in the two mechanisms of the respiratory support portion. So we have the dead space washout, and then we have that dynamic positive airway pressure that we're going to go over in a moment. And so what he was asking here is the decreased CO2 from the washout effect, or is the decreased CO2 because we're providing that pressure support that's helping the patient work less hard? And if we are expending less energy, then we produce less CO2. So I think it's a really interesting way to look at the mechanisms and how both of them together really help to deplete that CO2. So now going into that second portion is that dynamic positive airway pressure. Do you guys know why it's dynamic? I think I heard it. Your mouth. So your mouth is your biggest pop-up valve with nasal high flow. And what are our patients usually doing when they come in? They're telling us that they can't breathe. So that's why it is breath and flow dependent. It promotes slow breathing. By exhaling against that pressure, you're actually forcing the patient to almost purse lip breathe. And we have a great video that's going to show you that. Ooh, let me pause this real quick. So this is the Corley video. So what we have here is patients that were atelectatic following cardiothoracic surgery. And so what you're going to see is during exhalation, while on a simple mask, they were de-recruiting. So you'll see that blue fades to black, and that's the de-recruitment. However, once an initiation of nasal high flow was implemented, you're actually going to see all of the recruitment coming through. So let's go ahead and see what we have here. So this is low flow oxygen therapy. Breath in, breath out. Breath in, breath out. And then now we're going to initiate nasal high flow. And you can see the disbursement. So now we have alveolar recruitment, increase FRC, therefore we're increasing the surface area for better oxygenation and CO2 transferring from our blood to the alveolar space so we can exhale it. I find this video extremely beneficial as it gives us a visual of what we're doing with nasal high flow. Isn't that cool? So this is a great pressure and flow relationship done by Lee's systematic review. And what it states is as you increase your flow, you are increasing your pressure. And so one of the reviews that they did was done by Parks. You can see towards the end that was done in 2013 and 2015. And Parks said that for every 10 liters of flow, you are delivering a half to a full centimeter of water pressure at end exhalation. So that is your PEEP that you're delivering to those patients. That's why you have that recruitment at the end. So if you're at 60 liters, you can surmise that you're getting anywhere from 3 to 6 of PEEP with nasal high flow at end exhalation. So in regards to oxygen, the great thing is nasal high flow isn't just an oxygenation tool, it's really a flow tool. So we can deliver nasal high flow at room air. So if you have a trach patient that comes in that's having some issues with mucus clearance and maybe just work of breathing, nasal high flow is a great way to be at 21%. And you can go all the way up to 100% for those patients that are hypoxic. Okay, so this is a great slide. So this is understanding the concepts of entrainment. So us as normal breathing people, normal lungs, our peak inspiratory demand is anywhere from 25 to 30 liters, just to give you a basis. So if we look at the left, the patient is on a full face oxygen mask. So what FiO2 would you think that they're gaining? It's varied, and it's because the first 10 liters that this patient is receiving is at 100%. However, if they're breathing, if their peak inspiratory demand is at 30, that's 20 liters that they're going to entrain from ambient room air. That's diluting that 100%. So you really don't know what FiO2 you're delivering to that patient. Conversely, if you look to the left, with delivering nasal high flow, we're exceeding their peak inspiratory demand, and by doing that, not only we offset that work of breathing, but they're not entraining any ambient air. So whatever we have that oxygenation, whatever FiO2 is set, is actually what the patient is gaining. So you can feel confident in the drug that you're delivering. So optimal humidity. So humidification is an essential aspect for our patients. Most of our patients come in, they not only are they having some sort of inflammation or irritation that is seen with respiratory distress, but they probably also have increased mucus production. A lot of our patients come in dehydrated. And so if we're not humidifying the gas that they're receiving, that means that that's extra work that we're putting on that patient to humidify that air. So as it says, prevents the desiccation of the airway epithelium. And I have a great video. So this is the takeoff video. It is an amazing video that illustrates how just a deficit of 10% can really change the epithelium. So this is a microscopic view of the trachea. And what you're going to see is on the left, you're going to see flow being delivered at 100% humidity, so 3744. And the right, you're going to see at just a decrease of 10%, so 90% humidity. And most of us would say, that's great, 90%, woohoo. Well, let's see what happens. So if you look at the left, you see how the cilia are beating beautifully. They're going up and out. Those little particles are doing well. Conversely, after 15 minutes at 90%, you can see how the hairs are starting to be a little bit stagnant. Those little pieces could be the startup of an infection because they're not moving up and out. And after a duration of an hour, you'll see that the epithelium completely dried out. There we go. So the biggest takeaway from this is that a small reduction of relative humidity has an immense impact on your patient. Okay, so in summary, nasal high flow on the left. So as we increase flow, we're going to increase mean airway pressure. With increase the mean airway pressure, we're going to increase the end expiratory lung volumes, we're going to increase recruitment, and we're going to increase lung compliance. You can also add the FiO2 as needed to increase the PaO2. And with that flow, we're also washing out that dead space, which is going to increase CO2 clearance. All of that can be done with adding adequate humidity at 37, 44 milligrams of moisture, which will equal patient comfort. So all of this working together is going to decrease respiratory drive, decrease respiratory rate, and overall decrease work of breathing. So let's go into some evidence. So in the adult world, nasal high flow can serve as a primary support tool. We are increasingly seeing evidence and research supporting pre-oxygenation and prior to intubation. So not only are we oxygenating, but we're also stenting that airway open. And the great thing with that is you can actually do this while they're advancing the blade in the tube. So great aspect. In critical care, we often use this as we extubate patients. There's more and more papers coming out that extubating to nasal high flow can prevent your re-intubation rates. Some patients will require higher levels of oxygen post-surgery. And there's also utilization in all phases in the chronic lung issues. So this is taken directly from PubMed website, and it highlights the significance in publications and research. You can definitely see during the COVID years, it really amped up. And this is therapy managing both the acute and chronic phases of respiratory care. So let's go into a landmark study. This is the Ferrari-Fratt study, and it was published in 2015 in the New England Journal of Medicine. This 23-center study compared nasal high flow to non-invasive ventilation and non-rebreather. The results indicated that nasal high flow significantly reduced ICU mortality for both NIV patients and those receiving standard oxygen therapy. Additionally, nasal high flow decreased the need for intubation in your more acute patients, those with a PF ratio less than 200. There were also a significant increase in ventilator-free days, as well as a reduction of intensity to respiratory support and dyspnea. So this is just a quick slide that shows, this was taken from the previous FRAT study, and it's showing that fewer patients require intubation with nasal high flow when flow is being delivered at 50 to 60 liters. Remember, we need to exceed their inspiratory demand for these mechanisms to work. So we talked about hypoxic patients, and there's a lot of clinical research. Several systematic reviews have been examined in this clinical research related to nasal high flow. As a result, several professional societies now recommend the use of nasal high flow therapy for those hypoxic respiratory failure patients. So this approach is favored over conventional oxygen therapy and also non-invasive ventilation. Additionally, AARC and the ERS endorse the use of nasal high flow therapy compared to non-rebreather masks or nasal high flow cannulas, those cannulas that deliver the 10, 12, and higher ups. Not quite nasal high flow is what we're discussing here. Ooh, so this is a Smoky. So Smoky and colleagues published a meta-analysis, and that consisted of 99 nasal high flow studies performed in European Respiratory Review in 2017. So based on these studies, an algorithm was published suggesting the starting of nasal high flow at 60 liters per minute at 100% FiO2 for your acute hypoxic respiratory failure patient. So if you go from the beginning, let's start here. It says criteria for immediate or imminent intubation. So if no, of course, nasal high flow is the way to go. But what I thought was really interesting is it said if yes, you can still utilize nasal high flow as your pre-oxygenation and to help stint that airway as you intubate. It further goes on to how to titrate and then goes into weaning. And of course, we're going to first decrease our drug, which is our oxygen. So decrease your O's to less than 40%. And then we're going to start decreasing your flow by increments of 5. And if anybody wants to talk more about this, I can get really nerdy with this and we can have fun. I don't feel like everybody feels like that after lunch. So how do you know if nasal high flow is going to work? Well, we have the ROC study. So the ROC study is a fantastic study, and it's SpO2 divided by FiO2 over respiratory rate. So let's go, for example, I am, 95% breathing room air, and my respiratory rate is 15. My ROC score would be 30.2. Conversely, if we have a patient that's satting 95%, but they're on 85, and they're breathing at 37, well, their ROC score would be 3.0. So the authors confirmed that a ROC score greater than or equal to 4.88 is a great indication of success for nasal high flow. So we've gone over nasal high flow for your oxygen, and I know that everybody knows that, especially after COVID, how it's great for our hypoxic patients. But there is so much more evidence that's now coming out for our hypercarbic patients as well that suggests the use of nasal high flow. So the first study I want to talk to you is Cordigiani. So Cordigiani was published in 2020, and it was a non-inferior study. And so what they wanted to see is is nasal high flow non-inferior to BiPAP? And what they found is that it's not. They are not non-inferior. So what happened was they found that nasal high flow therapy is non-inferior to non-invasive ventilation in reducing the PCA2 levels in the first 2 hours. So both treatments demonstrated the significant effects on reducing PaCO2, and both trends were pretty similar in both therapies. What is really exciting is only 32% of those patients receiving nasal high flow had to be escalated to BiPAP therapy. So what we're saying here is 2/3 of your patients that present to the ED, we can actually rescue with nasal high flow as long as we're aggressive. So we implement it as soon as we realize that they're having issues, and that we do it where we're exceeding their inspiratory demand. This is a great one. This is Panzopoulos from 2020. So Panzopoulos published a literary review in COPD, Journal of Chronic Obstructive Pulmonary Disease, and it aimed to determine the suitability of nasal high flow. So we get this great algorithm. So what they found is if your patient is 7.25 to 7.35, nasal high flow all the way. However, if it's 7.25, NIV is the way to be for your first line of action. And let's be honest, you guys know those patients, they're the Voldemorts of the ED. You don't speak their name because they will show up. So those patients, we know who they are, and you can go straight to NIV. However, what was also interesting is that those patients that were unable to tolerate NIV were actually switched to nasal high flow in this study. Now again, with this study, flow rate started anywhere from 50 to 60. Titrate that FiO2 to keep SATs anywhere from 88 to 92, and temperature at 37. All right, so when are the effects of nasal high flow observed? Well, the respiratory rate is the best indicator of if nasal high flow is about to work. So what you can see here is a great little time frame, is that respiratory rate should decrease anywhere from 5 to 15 minutes, oxygenation should increase in 10 to 15, and dyspnea should decrease 5 to 30. So with all that being said, is that we're not masking any of the issues. You will know about in 30 minutes if nasal high flow is actually going to be effective in rescuing this patient, or if we're just kicking the can down the road and need to escalate. So we delved into the use of nasal high flow in the acute areas, but whether it's in home or pulmonary rehab, understanding the fundamental of nasal high flow and the mechanisms that work together, I think, is pretty imperative. And it also helps us understand why people are starting to utilize this more in your hypocarbic patients as well as your hypercapnic patients. So let's look at some other slides that are exploring the new and exciting developments in nasal high flow research and that are being utilized outside of the hospital. So this is a brief summary of several studies published recently highlighting the ongoing interest and also the need for clinical research in the areas of nasal high flow. So take a look. These are all the exciting research that is going on globally. These initiatives are diving deep into COPD, aiming to uncover the valuable insights of the effect of nasal high flow in comparison to conventional oxygen therapy. Sadly, there's not a lot out there in pulmonary rehab, but researchers are still investigating the application of nasal high flow. And they're comparing it to conventional oxygen therapy. One study I read, it was really interesting. Of course, the patient was actually able to work longer at a longer duration because of that work of breathing that they were offsetting with that nasal high flow. And these are the publications that examine the use of nasal high flow at home. And so sadly, we're still needing more, as you can see, but it's really exciting to see that we're coming up with different ideas of how we can utilize this application. One of the studies stated that the use of nasal high flow compared to those conventional oxygen therapies, the patients had less exacerbations. And looking back to the mechanisms, it makes sense to why nasal high flow is helping to support those patients. So do you guys feel like you know the mechanisms a little bit better? I spoke really fast, so I am so sorry. I have words in here to breathe. I didn't, so anywho. So thank you so much. Come see me at my booth. I really appreciate you guys. We got free high fives. Does anybody have any questions? Yes, ma'am. Yes. Let's see. Forgive me. I'm sure there's an easier way to do this, but like everything, I'm going to go the hard way. It's what I do best. There we go. Jean, do you have one of these? Why not? Come on. Does anybody else have any questions, comments? Awesome. Well, thank you guys.
I got a question.
Okay, yes.
Can I ask questions?
Yeah.
So One of the challenges with high flow has always been that we do it in the hospital, but then the transition home, it makes it really hard because there's no payment in the home. Do you know anything about where we're at with that?
I think that's a great question, and I wish I knew more. Sadly, that is still something that everybody's working on, and I don't really have a great answer for that.
Okay. All right. Thank
Please
you.
trust me, we get that a lot.
I'm sure you do.
Yeah.
Yeah. Thank you. Anybody else have
Guys.
questions?
Yes, sir.
So in the hospital, we got the big thermos bottle out there. Got the liquefied O2. How do you provide that at home? That level?
We don't. We don't. And moving into nasal high flow, not the oxygenation portion, but just high flow. Because but you do have a good point, because at high flow you're using a words are hard, concentrator, and so those usually are 10 liters. And so, I mean, there is a limit, a threshold that you're going to meet with those concentrators, versus at the hospital we can deliver up to 100%. Yes, ma'am. Yes. Yeah, well, we have lots of studies where that helps with the pushing out through the airway by having that positive pressure. So we can go into that here in a little bit. Yes. Yes, sir. Nasal high flow. Because we're going to have that better recruitment, and with that recruitment and that flow, we're going to actually help push some of that, with the pressure, we're going to push some of that fluid out. Because if you're at 60 liters, remember, if they're keeping their mouth closed, they can get up to 6 of PEEP. And what do we usually set a bi-level at when they come in? Maybe 15/5, 10/5? Yes. All right, guys. Thank you all so much. I appreciate you.